Welcome to today's Explainer. We're going to dive into a fascinating medical mystery today, and we're going to do it by looking at the real-world case of a patient we'll call Mr. S. It's a story about a hidden, systemic threat that millions of people just brush off as completely normal getting older, when in fact, it's a highly specific and, more importantly, highly treatable disease.
Listen to what Mr. S., who's a 66-year-old former HVAC tech, had to say. He told his doctor, "I had to retire early because the younger guys were doing laps around me. Now my legs get heavy and numb after just 2 blocks. I guess it's just getting older and arthritis." You know, it's such a common sentiment, isn't it? We hear it all the time. But what Mr. S wrote off as just the natural slowing down of old age is actually a stealthy medical condition that is literally starving his limbs of oxygen.
Okay, let's dive into this. What Mr. S is actually dealing with is called peripheral artery disease, or PAD for short. Basically, it's a condition where narrowed arteries reduce blood flow to your limbs. And when you look at the 2024 ACC/AHA cardiology guidelines, what's really wild is just how common this is. It affects about 8% of all adults over 40. And those rates, they spike dramatically as we age, peaking at around 20% in people over 80. That's 1 in 5 people in that age group.
Now, you might be wondering, wouldn't clogged arteries in your legs hurt like crazy? Well, the atypical reality here is that most patients don't actually get that classic crampy pain, what doctors call claudication. Instead, they feel this vague, stealthy heaviness, fatigue, or numbness that just kind of limits their walking. And because it's so incredibly subtle, patients like Mr. S unconsciously just reduce their physical activity to avoid the discomfort. They sit down more, they take the elevator, and they just assume, hey, I'm just getting old.
So the absolutely crucial point here is understanding when this goes from a chronic annoyance to a 5-alarm medical emergency. Exertional pain, which is what Mr. S has, usually improves entirely within about 10 minutes of resting. But if you or a loved one ever experience rest pain, meaning your leg hurts even when you're just sitting on the couch watching TV, or worse, it actively wakes you up in the middle of the night, that is a massive red flag. That indicates chronic limb-threatening ischemia, or CLTI. It means the tissue is actively starving, and without urgent medical intervention, there is a very real risk of losing that limb.
Section 1. The inequality of PAD. To really understand the scope of this, we need to look at Mr. S's background. As a black man with type 2 diabetes and a 40-pack-year smoking history, he perfectly represents the exact high-risk demographic that bears the absolute heaviest burden of this disease.
I mean, just look at this staggering number, 4 times. Let that sink in for a second. Despite having the exact same shared risk factors, Black Americans face a 4-fold higher rate of major limb amputation compared to non-Hispanic white Americans. It's shocking. And on top of that, they face a 30% higher rate of cardiovascular mortality and a 45% higher rate of stroke.
And this brilliantly illustrates the sheer disparity in the disease burden. We're talking about a lifetime prevalence of PAD that is nearly 30% for Black men and 28% for Black women. Compare that to the 19% prevalence in white adults. The gap is just immense, and sadly, it only widens as people get older. So what's driving this? Well, medical science is very clear that this gap isn't just about biology. It is heavily driven by social determinants of health, or SDOH. For instance, adults in the lowest income brackets have up to 36% higher odds of amputation. Insurance status, like being uninsured or on Medicaid versus having private insurance, is a massive predictor. But importantly, the AHA notes that these disparities persist even within public health systems. This points directly to deep structural barriers, things like lack of local access to specialty care, the cross-generational effects of structural racism, and the heavy chronic stress that comes with all of that. Section 2. Spotting the physical signs. Let's pivot back to the clinic with Mr. S. When a patient comes in complaining of heavy legs, what exactly is a doctor looking for during a physical exam to figure out if it's actually PAD?
Basically, the doc is trying to distinguish between the 2 major vascular systems, arteries and veins. Arterial disease, which is PAD, starves the limb of fresh blood, so the skin becomes cool, pale, and hairless, and the pulses, they're super hard to find. Now contrast this with chronic venous insufficiency, where the blood can't get back up to the heart. That causes warm, swollen, fluid-filled legs that can eventually take on this weird, inverted champagne bottle look because of all the tissue scarring.
Getting back to Mr. S, he is literally a textbook case of this arterial starvation. His legs are thin, the skin is shiny, and he's got noticeable hair loss on his toes. His toenails are thickened and brittle. His feet are completely cool to the touch, and when the doctor checks for pulses in his feet, they can barely feel them, grading them a mere 1+.
Section 3. The diagnostic approach. All right, so we strongly suspect PAD. But how do we officially confirm this diagnosis without breaking the bank, exposing him to radiation, or putting him through unnecessary risks?
Actually, scratch that. Before we run any tests, you might be asking who exactly should be screened for PAD in the first place. Should we all be getting checked? Well, the medical guidelines here are actually a little bit complex.
To give you the quick rundown, groups like the American Diabetes Association say all diabetics over 50 should be screened. Cardiology groups like the AHA and ACC recommend checking high-risk folks over 65 or over 50 if they have risk factors like smoking. But on the flip side, the Preventative Services Task Force says don't bother screening if you have 0 symptoms. Now, since Mr. S has both the symptoms and the risk factors, he absolutely qualifies for testing.
Enter the Ankle Brachial Index, or ABI. This is the gold standard initial test, and it is brilliantly simple. It's completely non-invasive. They just use regular blood pressure cuffs and a little ultrasound Doppler to compare the blood pressure at your ankle to the blood pressure in your arm. Because it completely avoids the radiation of a CT scan and the high costs of an MRI, it usually costs less than $100, it's incredibly cost-effective. An ABI ratio of 0.90 or less, that's diagnostic of PAD.
So Mr. S takes the ABI test, and his score comes back at 0.65 on both sides. Boom! This officially and definitively confirms his PAD diagnosis. His arteries are severely narrowed.
Section 4. Reclaiming quality of life. Look, getting a chronic disease diagnosis is terrifying, and Mr. S understandably asks, what does this mean for my future? This is exactly where we shift the narrative from fear to hope and look at the rigorous, guideline-based medical solutions we have available to help him.
But we must first be realistic about the stakes. Walk with me through this stark data for a second. For a patient who has PAD but doesn't have diabetes, the amputation incidence is 11.6 per 100 person years. But Mr. S has diabetes, and it turns out that bumps his incidence up to 24.2. That's a more than 5-fold increased baseline risk. And if you were still smoking, that risk would double again to nearly a 10 times risk multiplier. So treating him urgently and comprehensively is absolutely non-negotiable. Let's move to and see how this builds into the 3 pillars of reclaiming mobility. Modern medicine tackles PAD through 3 distinct steps: risk modification, medical therapy, and supervised exercise.
Pillar 1 is risk modification. For Mr. S, this means staying completely off cigarettes and keeping his blood pressure tightly controlled under 130/80. His blood sugar, measured by his A1C, needs to be optimized to under 7 or 8%. And crucially, he needs to be on high-intensity statin therapy, like Atavastin 40 to 80 milligrams. And get this, even if his cholesterol levels were completely normal, statins are practically mandatory in PAD to stabilize the plaques in his arteries and prevent heart attacks and strokes.
Now, regarding his diabetes, there's actually a cutting-edge advantage available to him right now. Drugs in the GLP-1 family, like semaglutide, are highly recommended here. In fact, the 2025 STRIDE trial published in The Lancet showed that semaglutide actually increases walking distance in patients with symptomatic PAD. Plus, emerging evidence suggests these drugs might even reduce nicotine cravings off-label. So it's an amazing 2-for-1 tool to keep him off cigarettes while protecting his vascular system. How cool is that? Moving on to Pillar 2, medical therapy. This is all about the blood itself. Antiplatelet therapy is crucial here to keep the blood flowing smoothly through those narrowed leg arteries. For your average patient, something like clopidogrel works great, but because Mr. S is a high-risk patient with symptomatic PAD and diabetes, guidelines from trials like the COMPASS trial suggest he'd benefit immensely from combining a low-dose blood thinner like rivaroxaban with daily aspirin.
And finally, Pillar 3, I love this because it's so ironic. The absolute most effective intervention to directly improve the pain of walking is, literally, more walking. Supervised exercise therapy involves structured clinical walking programs that literally force the body to develop new, tiny collateral blood vessels around the blockages. It is a total game changer for quality of life. And if exercise alone isn't quite cutting it, a medication called silostazol can be added to help widen those vessels and boost his walking distance even further.
We have covered a lot of ground in this explainer today, from the stealthy, hidden symptoms of PAD to the incredible multi-pillared medical tools we have to fight it. So I want to leave you with this question. Think about your loved ones. Is their slowing pace really just old age? Or could it be a stealthy threat like PAD just waiting to be properly diagnosed and treated? Thank you so much for exploring this vital topic with me today. Keep asking questions and keep learning.